Thank you. We as the World Bank are honored to support this event, and a direct link runs from this Guildhall today to the global challenges that the World Bank faces. I want to suggest that managing urbanization will be the defining challenge of the next century. And the knowledge that we gain today, whether in London, Vancouver, Bogota, or elsewhere, will help us to manage the urban challenges of tomorrow. And what remarkable challenges they will be. Simply consider the demographics. World population will exceed 10 billion by 2100, but the changes in the structure will be phenomenal. Africa will grow fastest, to 4 times the size of Europe, and to approach the size of Asia. Nigeria, with 750 million people, will be the 3rd largest country in the world. Tanzania, with 320 million, the 5th largest in the world. Afghanistan will be larger than Russia, and Niger will be larger than both of them. Almost all future growth will be urban, as rural areas shrink. In 1950, when this Guildhall was declared a Grade 1 listed landmark building, and when Clement Attlee was narrowly re-elected, 30% of the world's population lived in cities. By 2008, for the first time in history, half of humanity lived in cities. By 2025, 2/3 of us will live in cities. And the structure of the world will change profoundly. By 2025, there will be 26 megacities, defined as cities with over 10 million people. There'll be another 59 cities with 5 million or more people. And 3/4 of these will be incipient megacities, and will include cities such as Lagos and Kinshasa, where the urban challenges will be immense. There'll be a further 573 cities above 1 million people. But wait for it, China alone will have 262 cities of 1 million people or more. That's why I believe that managing urbanization and the issues we've discussed today will be the defining challenge of the next decade. Urbanization can unquestionably be positive. It offers unparalleled economic and social opportunities. As the eminent Oxford historian Paul Collier points out, density is the handmaiden of economic dynamism. And there's no question that cities drive growth. McKinsey, for example, estimate that 600 cities worldwide, with 20% of global population, will account for 65 trillion in produce over the next 25 years and drive 65% of global growth. And we all know that cities are the crucibles of education, science, and the global knowledge economy. Simply consider the arc of universities within a mile of this Guildhall that have made London a center of knowledge and innovation. And rapid urbanization need not be insurmountable. Simply consider London. In the 19th century, it grew from 1 million people to 6 million people, as fast a pace as the most rapidly urbanizing African cities today. But in spite of this, we have to acknowledge that cities concentrate and incubate new health challenges, particularly rapidly growing cities, particularly the new megacities, the Kinshasas, the Lagoses of tomorrow. Simply consider the challenges that those of us managing such cities will face over the next 25 years. By 2025, a majority of the world's poorest people will for the first time live in urban areas. Globally, 1 in 3 urban dwellers, 1 billion people, already live in slums. And in the poorest countries, Bangladesh, Ethiopia, Haiti, up to 80% of urban dwellers live in slums. They lack rights and are frequently voiceless. Land pressures and land policies frequently drive people to live in the least safe parts of cities, such as flood-prone Dharawi Asia's largest slum in Bombay. Urban air pollution kills over 1.2 million people every year, overwhelmingly in developing cities, overwhelmingly through vehicles and the use of indoor fuels in the poorest countries in South Asia. Road accidents are the leading cause of death among young people worldwide, and their toll in developing cities is immense. We have accident rates that are 50 to 100 times higher than in the West. We know, and we had a marvelous presentation earlier on violence, that urban areas are often unsafe, especially for the young, for women, and the elderly. We also know, and this has been beautifully illustrated in this meeting, how cities often discourage exercise and mass market the least healthy foods, fostering the epidemics of non-communicable diseases that we now face. And many developing countries face the twin burdens of both infectious and non-communicable epidemics concurrently. The interaction of dense urban living and newly emerging viruses presents a constant challenge. Simply consider how quickly SARS broke from rural China to Beijing and Hong Kong, Toronto, and the world. We also know that existing infectious diseases are higher in cities in the developing world. For example, in Kenya, immunization rates in low-income urban areas are lower than in rural areas, and childhood diseases are higher. In New York, TB is 4 times the national average. 80% of the Congo's TB cases are from the 20% of the country that's urban. And in Africa, HIV rates in urban areas are at least twice the national average in their countries. Finally, and this meeting has profoundly illustrated this point, we know that urban milieu often exacerbate harmful health behaviors, including mental illness, violence, alcohol and drug dependency, and risky sex. And that's been a major theme of the last 2 days we've spent together. When I lay out all of these challenges, they seem formidable. Can we overcome the immense challenges of urban health over the next century, particularly in the rapidly urbanizing megapolises of the global South? I believe we can, but if and only if we can truly distill the evidence and lessons of experience from existing urban practice. And I would like to devote the rest of my comments to some of the principles that I think can guide us to manage urban health better over the next period. And I think the first point that's been beautifully illustrated in this meeting is the critical importance of solidarity and inclusion. Consider the inspiring presentations from Bogota and Medellin in Colombia, showing that cities with a shared conviction of civic citizenship and purpose can overcome even the cancer of global drug cartels. And take my own field, AIDS, where the global AIDS movement underscores the transformative power of solidarity, the determination of northern AIDS patients, activists, scientists, and ultimately taxpayers transformed global health from a multi-million to a multi-billion-dollar solidarity fund and ensured that virtually everyone on Earth now has access to life-saving treatment. There's no question that solidarity is one of the most powerful principles that underlie whatever we achieve. And I think the lesson is simple. Cities inspired by solidarity and inclusion to create a shared civic citizenship can protect the most vulnerable and ultimately thereby improve the quality of life and health for all residents. And my point is simply that solidarity is smart urban development, it's good economics, and it makes cities better for all of us to live in. The second point has been beautifully illustrated throughout the meeting, and that's the importance of voice and participation. The presentation from Terence Higgins Trust, which distilled the principles that they've learned into global movements, showed how voice and participation are prerequisites for sustained, effective health outcomes. And again, in my field, the remarkable success of community-led HIV prevention among gay communities in the West before we had any effective treatments is powerful testimony to the transformative power of community leadership and participation. And beyond that, the AIDS movement in gay communities in the West really revitalized the gay rights movement that we now see changing fundamental norms and laws in the West. I think the third point we need to keep emphasizing is that options and choices really matter. Different policy choices have different outcomes, and these outcomes matter. If we disregard the evidence, if we choose the wrong policies, people remain homeless, mentally ill, addicted, overdosed, infected with an irreversible virus, or even dead. The difference between supporting and opposing proven harm reduction approaches is not benign. It matters. Which leads to my fourth point. Knowledge and evidence are integral. I believe that knowledge and evidence-based practice are more vital than ever, particularly in a climate of austerity and skepticism about many public health initiatives. And evidence truly can matter. In my own institution, the World Bank, we were able to show that providing cash transfers to very poor people transformed their health, their access to education, their protection from catastrophe. We were able to show so much good evidence that these cash transfer programs, such as Oportunidades in Mexico, Bolsa Familia in Brazil, are now an integral part of the national social welfare systems of whole nations. The evidence mattered. It was worth investing in strong evidence. And I profoundly believe that we've got to increase our emphasis on really meticulous evaluation and much more closely integrate town and gown, research and practice, pursuing a model of inquiring practitioners and embedded scientists. I don't believe that public health can be bifurcated into practice and research. We have to strengthen our evaluation, our impact evaluation capacities in both practice and academic science. We've got to be confident we're promoting proven approaches, and we've got to be confident we can defend these approaches. Fifth, I think we do live in an era where cost effectiveness is inescapable. And we know that good public health interventions are smart investments, and we know that they have health and social benefits, but we're not always able to quantify these returns and to cast them in economic language. We've got to increase our emphasis on cost effectiveness, and we've got to be able to demonstrate that good public health provides good, clear returns. In short, we need better partnerships with health economists. We need greater literacy in economics, and we need greater fluency in advancing economic arguments. We need an alliance between public health, evaluation science, and economics. It's the dominant language and currency of decision-making in our era, and we need to use it. The sixth point I want to make is that cities concentrate and incubate intelligence and innovation will continue to transform urban and global health. The last 20 years have witnessed unprecedented and accelerating scientific and technological progress. Take my own field, AIDS, and take AIDS treatment. Just 2 years ago, we had few tools to prevent deadly infections and no drugs to commute slow, agonizing, wasting death. Today, we've got an ever-expanding armory of proven prevention approaches. We have more drugs to treat AIDS than every other retrovirus in history combined, and we've reduced the costs of treatment from $10,000 to less than $100 in less than a decade. Continued innovation in basic science, in technology, in delivery, in management, and in social organization is going to continue to transform urban and global health. And cities have to capitalize on their greatest asset, concentrated distilled intelligence, to drive and apply innovations. I think if there's one thing we can be certain of, it's that breakneck scientific and technological progress is going to continue to expand the frontiers of practice. The seventh point I want to really stress, more mundanely than the previous point, is a point that our new World Bank president, Jim Kim, himself a TB and HIV physician, makes, and that is, service delivery is a science. Karen McCluskey put it beautifully in her earlier presentation. Most failures happen at delivery. They fail at implementation, at execution. Many countries and cities have strong public health policies and programs on paper, but they're not getting the results they want. The challenge is delivery. Delivery means implementing the services that will achieve the desired results. And the public health field has some outstanding delivery success stories we can build upon, but we don't draw upon them often enough. We don't break away from business as usual. Take the famous example of Unicef's expanded program on immunization, which removed all roadblocks to immunization to quadruple immunization rates in developing countries from 20% to 80% in 4 short years. Take PEPFAR, the largest global health initiative in history, which put 8 million people on complex treatment in less than a decade. Or take India's famous Avahan program, which took the best of the private sector to develop delivery science principles to bring programs to sex workers in the poorest Indian cities, halving HIV in India. These programs share some common elements which I think define delivery science. The science of ensuring that services reach the people who need them. And I think some of these principles are an explicit focus on goals and an undeviating focus on results. Second, a focus on the biggest drivers of results, a preoccupation with the biggest factors which will lead to the largest changes. Third, a real absorption in the details of implementation. Fourth, an emphasis on problem solving, not processes or procedures. Fifth, a quest for real-time program data and a willingness to make major changes in response to real-time data, something we so often lack in public health relative to many private sector initiatives. Next, incentive systems that reward us for rapidly identifying failure, that reward us for smart risk-taking, and that reward us for urgent problem solving. And above all, an execution focus, a can-do, must-do ethos that cuts through problems. I reiterate, the science of service delivery is the next frontier for public health, and it's the next frontier for development in general. The greatest failures occur at execution. The final point I want to make is that urban health, and this is the most exciting part of it, is truly transdisciplinary. We all know this. It's influenced by town planning, by engineering, by water and sanitation, by transport, parks, recreation, education, commerce, the private sector, community associations, churches, and the media. But the point is, we need new integrated health solutions that focus on problems and their solutions, not on formal professional disciplines. We've got to address problems through approaches that are wholly transdisciplinary. After all, we as urban dwellers live in cities, not in sectors or in departments. Now, this is basic, but our business models haven't begun to catch up yet. And we have to start reorganizing our business models around intermeshed problems and integrated solutions. And again, take my organization, the World Bank. Many of our smartest country partners no longer think in terms of health projects. They think in terms of healthy, educated, well-insured, productive citizens. That's the solution they want, and they want to draw upon the totality of disciplines to achieve it. And to put it very simply, a comprehensive, well-integrated urban renewal project, a slum upgrading project, is a better platform for public health than a narrowly targeted health intervention. So we need to break down boundaries and work in a truly transdisciplinary way. In conclusion, urban health, global health, face some immensely complex challenges. But we should be undaunted as we prepare to pass the torch to Glasgow another city with a rich and influential global history, where, for example, Joseph Lister invented modern antiseptics and sterile surgery, which has certainly saved my life and many of us in the room today. And as I look at this marvelous hall where we've gathered for the last 2 days, I doubt that any of our forebearers gathered here, even at their most ebulliently optimistic, would have believed the scientific and technological progress we've made in education, in health, in understanding. And so much of urban health, so much of what you've described over the last 2 days, the fight against mental illness, against addictions, against diseases such as AIDS, shine a light on what's best and worst in us as a society. And when we respond with prejudice, we're at our worst. But when we respond with science and compassion, then we're at our best. And I think when we measure ourselves against these principles, it's remarkable and clear how much progress that we've made. For all the challenges we face in this economic climate, there's never been a better time to be alive. There's never been a greater likelihood that one will survive, flourish, and have opportunities that our forebearers could only have dreamt of. And for that reason, I close by suggesting that let this conference and its successor in Glasgow peer through the current economic mists and join the great Anglo-Scottish polymath Thomas Babington Macaulay, who said, "On what principle is it that when we see nothing but improvement behind us, we are to expect nothing but deterioration before us?" Thank you.